So we are live now. Good afternoon, everyone. I am Dr. Kirti from Dr. Makkar's Diabetes and Obesity Center. Good afternoon, sir.
Good afternoon, Dr. Kirti, and good afternoon, everyone who's joined for this program.
In recent times, what we are seeing is so much of advancement in technology, whether we talk about smartphones, cloud-based solutions, or electric vehicles. So, sir, my first question to you of the day is, are there any new technologies in the field of diabetes management also?
Yes, in fact, there are a lot of technologies that are, being used or they have evolved and impacted the way diabetes is being managed today. So there have been tremendous change with development of newer technologies uh, right from the beginning. uh, in terms of understanding how diabetes is caused. Earlier, we used to think that diabetes is caused only because there is decrease in insulin level in body, and that is why the people get increase in sugar level. So now we know that it is not just insulin. There are multiple mechanisms which are leading to increase in blood glucose levels in body, and that is why you need to use multiple drugs. Now, once you know there are multiple mechanisms, this understanding has led to development of newer drugs for management of diabetes. Then there are newer techniques which have made the diagnosis of diabetes easier, much more easier than it used to be. There were times when we used to test urine sugar, had a test tube, you boil the urine, say put some reagents and see the color. And again, you didn't know how much sugar is. You just could make out that there is sugar, yes or no. Now you have so much precise techniques and you can just do with finger prick, you can make a diagnosis of diabetes. Similarly, in terms of treatment, new drugs have come up because of the better understanding of underlying mechanisms. There are smart drugs which have been developed with better delivery of the molecules. There are smart insulins that have been developed. There are better drug delivery devices that have come up, and so on, and better monitoring devices. So many things have developed in terms of improving diabetes care over last, I would say, majorly last 2 decades. There has been a tremendous change in developments.
So, sir, you mean to say that advances in technology has impacted each and every aspect of diabetes management?
Yes, absolutely.
So, sir, I would like you to take one by one each and every aspect and just clear the things to us. Let's start with understanding the underlying mechanism of diabetes. How has technology impacted it?
So, earlier we had the understanding or the research was limited to few laboratory parameters and few, tools like microscope, which finally went on to electron microscope and things like that. With the advent of newer technologies, we are able to actually, develop very, very precise molecules which go and interact with the target molecules or target mechanisms that are suspected to be causing increase in glucose levels or other abnormalities in body. And with those kind of targeted interactions that are created in the laboratory, now we know that it is not just one pathway, that insulin resistance or insulin deficiency, that is causing diabetes. We know that there are multiple mechanisms which are contributing to development of hyperglycemia or the increased glucose level of diabetes. Earlier, we used to think, that person is passing more urine in your glucose in urine because the blood glucose level is raised, and the excretion of glucose in urine is actually abnormal thing which is happening because of diabetes. Now, with the understanding of mechanisms that kidney is actually, absorbing more glucose than it should, and it is retaining more glucose in body than it should excrete, and contributing to increased blood glucose levels. So we always thought that kidney is, throwing out more sugar, while actually it is not throwing more sugar, it is throwing less sugar than it should be throwing. And now we have molecules that change, that block this mechanism, that they block the kidney function, that abnormality that is leading to increased absorption of glucose from kidney, to increase excretion of glucose. So we are using drugs which actually increase glucose excretion in urine. Earlier we used to think now urine is not having glucose, that means we are doing a good job. We didn't know that it is still absorbing more glucose than it should be absorbing. So things have changed. So we know that there are multiple mechanisms. We know it is not just pancreas and insulin. Liver is playing important role. Even the fat tissue is playing important role in causation of diabetes. Kidney is contributing to development of diabetes. Even brain centers are involved in, increase in insulin resistance and increased glucose levels. So multiple things are there. And all this understanding has been possible because of the various technologies that have developed and helped us in improving the laboratory research.
So diagnosis is also very easy because of this technology.
So yes, so see, first thing is how we diagnose diabetes. So we used to do a blood sugar level to diagnose diabetes. So the standard was you do a fasting glucose and you do a postprandial glucose, and every time you have to go to laboratory to get a test done, right? And the urine sugar was also done to make sure that urine sugar is positive or negative. Now, initially urine sugar was done by putting some reagents and boiling it in test tube. Then we got simple dipstick strips that you just dip the strip in urine and you know whether there is increased sugar or no, and you have a rough idea how much it is increased. Now we don't test urine for sugar. It is not required. We just do blood test and we simply do with simple finger prick, right? And immediately we know the results. Then important thing was we used to look at A1C as an important parameter of overall control, and now it has become a diagnostic criteria also, because sugar fluctuations may be happening. So one sugar value may not be diagnostic. You may have to repeat. But if you have a A1C value which is high and sugar is high, then you are very sure that person has diabetes. Now, A1C was done by standardized techniques which are standardized to a specific program called NGSP, which is standardized program from US related to a specific clinical trial which used A1C and which brought A1C into use. Now we have simple finger prick testing for the A1C, and it is as good as NGSP standardized method. So we don't need to send the person to lab to assess A1C. All you need is blood sugar fasting or random or A1C to diagnose diabetes, which can be done with simple finger prick. You don't need to send the person to lab for making a diagnosis.
So let's talk about the treatment options. Has technology impacted that part also?
Absolutely. A lot of things have happened. So as I mentioned that we have started understanding that there are multiple mechanisms which are leading to increase in blood sugar. It is not just decrease in insulin secretion or increased resistance to insulin. Now, once we understand that there are multiple mechanisms, the next step is to intervene into these mechanisms to bring down glucose. So once you know multiple mechanisms, you develop drugs to target those mechanisms which are abnormally contributing to glucose level. So this led to development of different drugs acting on different pathways and not just improving insulin or decreasing insulin resistance. And they all can be combined to treat multiple pathophysiologies that are involved in leading to increase in glucose level. So in last 20 years, actually we have seen fantastic drugs which have come up, the new drugs, which are not only improving glucose levels, they also improve they protect the target organ damage. They protect kidney damage, they protect damage to heart, they are able to reduce the risk of complications. Also, there used to be major challenge whenever when we were using the conventional drugs, there was a risk of lowering blood glucose too much and get hypoglycemia, which was a major reason why people were not going towards control targets, because people were afraid that if they go too low, they will get hypoglycemia, and that can be a big problem. That is an emergency situation. Now, these drugs, newer drugs, they do not cause hypoglycemia. They will bring down the sugar levels, but they will go to a level which is normal, and below that, they will not act. So you have drugs which are bringing down sugar but not causing hypoglycemia, which was a major deterrent to improve glycemic control. Similarly, you have, as I mentioned, that we were thinking that urine excretion is good. It is because of increased glucose in blood. Now we know actually kidney is not excreting enough. So we have drugs which improve kidney function and lead to more excretion of glucose from body, which helps not only in lowering blood glucose but also helps in weight reduction. 70% of the people with diabetes are overweight or obese, maybe 80%. So earlier drugs used to cause weight gain. Now we have drugs which are not only lowering glucose, they are protecting heart, kidney, lowering weight, not causing hypoglycemia. So all the important factors that we were looking for a drug, we are now having multiple drugs with those kind of attributes.
True, sir. So let's talk about insulin. It has been roughly 100 years of insulin. And has there been any advances in the tech because of which the insulin has improved?
Yes, again, insulin actually it is more than 100 years. We crossed 100 years last year only. And insulin is a lifesaver molecule for diabetes patients, especially type 1 patients. Now, if you look at the first batch of insulin which was produced basically it was a purified pancreas extract. So it had a lot of impurities, and the average insulin concentration per ml of the injection liquid was only 10 units. And the impurities were significant, very, very significant. And even, when we were using the conventional insulin, I am talking maybe 30 years back or 35 years back, we were having an impurity level of going up to 10,000 parts per million, right? So that kind of impurity level was there. And because of this, there used to be local site reactions, allergies, and because the volume of insulin required was initially more, so because it was only 10 units in 1 ml, so you needed larger volume to be injected, so it was more painful. Needles were thick, so it was painful. Now currently the insulins that we have a concentration going up to 100 to 300 units per ml. So the volume injected is reduced by 1/10 to 1/30th of what it used to be right at the beginning. Second thing is the impurity level is now acceptable range is less than 10 parts per million. So imagine from 10,000 parts per million, impurities have come down to less than 10. Then the conventional insulin used to act in a particular manner, which was not very much compatible with the normal eating behavior or normal eating pattern of a normal individual. So we needed insulins which will match the normal insulin secretion which happens in a normal individual who does not have diabetes. But when we were giving insulin from outside, we could not create that matching. So that led to development of designer insulins. We have been able to develop insulins which are specifically designed to take care of your continuous insulin requirement that happens 24 hours, whether you are sleeping, whether you are eating or you are not eating. And you have specific insulins to take care of sharp glucose increase that happens after meals. So you can use different permutation combination of different insulins to actually mimic the normal insulin secretion that happens in a normal individual, which was not possible earlier. So we have now smart insulins or designer insulins, which are the analog insulins, which give you much more flexibility of usage. Earlier, person had to take insulin shot 30 minutes before or 45 minutes before the meal because the onset of action was delayed by 30 to 45 minutes. Now the insulin that we have that starts action within 5 to 7 minutes. So person has to take insulin just before the meal or even with the meal, does not matter, right? Second thing was person who has taken insulin in the morning had to make sure that he is eating lunch also on time. Now it is one shot, one meal. So if you want to take breakfast, you take your shot with breakfast. You want to skip lunch, skip your lunch dose. You want to have dinner. You want to have early dinner, you have your dose early with the dinner. So it gives you a lot of flexibility in lifestyle. So all these things have been possible with because of the development of various technologies where we have been able to modify the structure of these insulins to behave in a way that is required or that is desired. So that is why these are called smart or designer insulins.
Actually, sir, we can say these developments have changed the life of a diabetic patient who need insulin.
Yeah, actually, smart insulins are in pipeline, which these are designer insulins. So work is going on that as of now we still need to calculate the dose of insulin. So work is on to develop insulins which are injected, but they will not get absorbed till the glucose goes up, and they will get absorbed only in a portion that will bring down the glucose, and once the glucose is normal, again the insulin will not get absorbed. So it will be kind of depot providing insulin as and when glucose is going up. So these kind of things are also being developed. These are going to be smart insulins which will act based on the glucose levels, and all these things are in pipeline.
Now let's come to the monitoring part. As we all know, monitoring is a very important aspect of diabetes management. So we would like to know more about how technology has impacted monitoring of blood glucose levels.
So most important thing to understand is that blood sugar level is continuously, going up and down in people who have diabetes. And unless you know how the blood sugar levels are fluctuating or behaving during 24 hours time, you cannot decide what kind of treatment is going to be appropriate for the person. So you need to check sugar multiple times. So now we have glucometers which are easy to carry, which are lightweight, which are simple. The pricking devices are very good. You don't see the needle, just put and click. You will get a stab and sugar, the blood will come out. Now, earlier glucometers, the pricking devices were, using thick needles. You needed a bigger drop size. Now you need only 5 microliters. 5 microliters is very, very tiny drop of blood. Earlier we were using color coding, colorimetry, so color matching was done by the device to read glucose. Now it is much more precise. There is the strip that you are using in glucose meter is basically having a very, very precise circuit. So once the blood is sucked into the strip, it leads to electron transfer between two electrodes. And the amount of electron transfer that happens actually is proportionate to the glucose level that you are having. And that's how it reads. So the precision has improved much more. The average deviation, still it is not 100% accurate. Most of the new glucometers give you accuracy within 10% range, which used to be close to 20% with the earlier glucometers. So there used to be wide, variations in the range of glucose that you were measuring. They have become smaller. Now you have connected glucometers. They also give you indication, there are lights or the coding marks that your sugar is normal, it will show in green zone. Your sugar is high, it will show in red zone. Your sugar is low, it will show in blue zone, and things like that. It will give you alert. So all these things have been possible now with development of technology only, and things are becoming cheaper. So I first time I purchased a glucometer 30 years back, it used to cost 5,000 rupees. Now the currently a new good glucometer with Bluetooth technology costs only about 1,400 rupees. Imagine the cost of 5,000 rupees 30 years back and 1,400 rupees in today's world. So it is not only the technology has improved, the cost has come down and availability has improved. And that is why the use has improved and people are able to measure their glucose right in the comfort of their home. They don't need to travel to labs to check their sugars, and they are able to monitor nicely. So all these things have been, they have been possible only because of the development of various technologies.
So there's a question from the audience. Can I have it?
Yes, why not?
What's your view on IoT-enabled glucometers, which can update patients' results to doctors immediately? Is it a useful technology or too futuristic?
No, it is not futuristic. We have glucometers which are, which are connected to a software which doctor has. It is available, I think, now more than 5 years or so. Important thing is, why do you want every reading to be flashed to doctor? Do you think a doctor is going to see every patient's every single reading of glucose? It is not possible. Fine, it should sync with the doctor system so that whenever you go there, doctor has a record of your glucose levels. That's perfect. But more important thing is, you as a patient, there is a big role of diabetes self-management education, DSME. You have to understand your disease. You have to learn and educate yourself about your disease. You should know that if your glucose level is this currently, whether you need to, act on this, react for this level, or you need to ignore this, or this is fine, or this requires a consultation with the doctor. So the glucose values, as long as you are keeping it in your record, whether it is the record within the glucometer which is synced with the phone, and from phone you can take a printout, or you can sync with the doctor's software where the report gets imported as a chart. All these things are possible. There is nothing futuristic. We have connected devices now, even the blood pressure monitors. Once you measure blood pressure, it can come to my record. When you measure your body weight, again it can come to my record. But importance is not that doctor is checking your record right every minute. It is not going to be possible anywhere. It is not possible in any country. So important thing is, once the patient is visiting the doctor, there is already a glucometer record there. Most of the places, even in US, if you go to a diabetes center, you have to carry your glucometer there. The nurse will take your glucometer, connect with the soft computer, and take a printout of your reading. So it just gives you, it doesn't, you don't need you to keep recording manually. It is there in your system. But it is not going to doctor to create an alert. That is practically not possible. But yes, technology, everything is possible.
So we were talking about drug delivery devices also. Can you explain, put a light on how technology has impacted it?
Yes. So first thing is, initially, the formulations improved by change in the formulation techniques, from the coarse powders to the finer powders, to the appropriate content of moisture or drying technologies, then coating technologies. Now important thing is, you need a drug which is required for 24 hours, and the drug has a half life, say, of 2 hours, and the effect lasts for 6 hours. So you were given 3 doses of metformin, and you were taking 3 doses of sulfonylureas to begin with. Then we got longer acting formulations, longer acting molecules, and the shorter acting molecules converted into a longer acting or slow release or sustained release form. So instead of taking 4 tablets, you started taking 1 tablet, right? Then you started getting drugs which were not causing weight gain, which were not causing low sugar levels, which were compatible with other drugs. Now, still, if you are on 4 drugs, you were taking 4 drugs. Then we started getting combination pills, multiple drugs combined into one pill. Now, once you are combining drugs in one pill, they can actually interfere with each other's release, action. There can be a lot of interference. So we develop technologies that we combine drugs, combine the benefits of all the drugs in one pill without increasing the side effects or without compromising on the quality of effect of the drugs, right? Then drugs were causing, say, gastritis. So you got the form which is slow release and the gastritis was lower down. So all, and now with the newer technologies available, we were getting earlier, insulin till now is injectable because it is a protein. So we started getting other classes of drugs, protein molecules, which were given as injectables like GLP-1 receptor agonists. Now, problem with these things is that if you make them into pill, they are, because they are protein, they are digested like food. So in stomach, there are protein digestion enzymes which will digest them, break them down, and there is acid pH, which again disintegrates these. So they are, digested in the stomach, and they cannot be absorbed as the drug. Now we have been able to convert these protein molecules into a form which does not get digested by combining them with other molecules and also changing the pH at the point of absorption. So we have been able to combine protein molecules with a molecule which not only prevents its breakdown but also increases its absorption into the circulation. So instead of given by injection, the same protein molecule now we are able to give as tablet, and the first one is already in market. And we hope that some point of time, even insulin will get converted to a tablet form. So this is how the drug delivery systems are changing. They are improving, and they are giving you benefit of reducing the number of pills that you have to take. Maybe some point of time we will be rid of all kinds of injections if we are able to convert them into pill therapy, which is a big convenience because not everybody wants to inject. In fact, nobody wants to inject any drug, on self. So all these kind of developments have led to tremendous improvement in the, ease of management and improve the adherence to management. Somebody has to take injection, frequently will try to miss injection. Somebody has to just take a pill in the morning, will take a pill every day. So there are a lot of things that have changed in this segment also.
Sir, I'll take one more quick question. Do you feel telemedicine and social media is also an advancement in technology which is helping diabetes management?
Absolutely. That's what we were talking a few minutes earlier, that you have connected devices. So you check your blood sugar, my system gets a record of your blood sugar. You check your blood pressure, my system gets a record of it. You check your body weight, my system gives a record. So, and you do it 5 times a day, all 5 readings are registered in my system. So when you come, I just click the button and I see, oh, last 2 months, the sugar has been doing fine, your blood pressure has been fine, but your weight has increased by 1.5 kg. So it is just click of button. I don't need to go through all kinds of records. Person doesn't need to, So this is the advantage of development of telemedicine or connected devices. Now it is not just telemedicine. It is, I think, much more than that. We are having Bluetooth connectivity. We have infrared connectivities and so on. And this connectivity with utilizing the internet has changed a lot of things in the way we manage, or we manage not only the disease but also the patient. And patients can access data. They can look up videos on YouTube. Earlier, if you had to understand how will you inject using a pen, so you have to be trained by a nurse or a doctor. Now all you need is go to YouTube, how to use insulin pen. They will show you everything step by step.
But
so,
please,
yeah.
But sir, we would request our audience to please rely on reliable sites. Don't go by the.
Yes. So it is very important to make sure that you are getting the authentic information. And there are very authentic websites. There are very important websites which have very large patient information portals integrated into them. And one of them is, International Diabetes Federation. You can check a lot of information relevant to patients. And you can also check on diabetes.org, which is American Diabetes Association website. There's a full patient section there. In fact, if you go to that site, professional section is, a separate link. So once you land on that website, everything is largely general information which can be of use to patients. So there are very good sites and there are very good materials available on internet which can be of help.
Sir, I would like to interrupt. We also
Yes.
have our own website, sir, and we are
Yes.
also trying to do the same.
Absolutely. So we, in our own website, we have, I think, tried to solve most of the common queries. We have, FAQ pages on diabetes and obesity and related comorbidities and all basic things we also have on our website, which is diabetesandobesitycenter.com, or you can simply put drbmmakkar.com or drmakkar.com. You will, go to that website. But I wouldn't say that we are anywhere close to those big portals which are updating their information on daily basis. So basic information, yes, we have pretty decent information on our website also.
And so through this social media, we are trying to impart scientific evidence-based knowledge to our audience.
And that is what we are doing right now. So that's this Facebook Live is actually one of the small steps that we are trying to take in terms of improving patient awareness and education on various aspects of diabetes and obesity that we see commonly in our routine practice now.
Sir, can we conclude today's session?
I think so. Though we have a lot of other things to talk, but we can do, part 2
Yes.
next time.
Because it's a very extended topic, and I think we need to go for the second part.
Yes, we can do that.
So thank you everyone for joining.
Thank you everyone, and we will discuss some more things that we have not been able to touch upon, like advances in monitoring techniques, advances in insulin delivery, use of pens, pumps, connected devices, and so on. So let us hope to have some more information which is relevant to people who are logging in, and I hope that you are finding this information useful. And for more information, you can actually log on to our website also. So there is good information on our website. Till then, see you. Thank you for joining, and let's see you again on next Thursday at 3 p.m.